All right, all, welcome back. We're going to talk a little bit about benzodiazepines and their addictive potential. So, this is a figure taken from a meta-analysis of self-administration animal studies. When I say meta-analysis, what I'm talking about is they're looking at a bunch of different self-administration studies and then putting all of their results together in one paper. Right, so let's look at diazepam. That is one of the classic benzodiazepines. So this is cocaine. This is vehicle. Um, they're looking at injections per day. I believe these studies were done in monkeys. And as you can see, compared to cocaine, diazepam has a relatively low self-administration. Buspirone is a non-benzodiazepine anti-anxiety medication that, of course, is not reinforcing. Animals will self-administer diazepam, but not at a high rate. Phenobarbital, which is one of the classic barbiturates, has a much higher self-administration rate, and it is dose-dependent. So higher doses are more reinforcing, and for benzodiazepine, that's not really the case. Right, so animals can self-administer benzodiazepines, but not at particularly high rates. Right, some of the classic themes that you see through benzodiazepine self-administration and reinforcement research is looking at the fact that benzodiazepine addictive potential is often assessed relative to other drugs. So it's considered either low or moderate risk. So zolpidem, which is Ambien, I'm sorry, I'm so bad at these names. Midazolam, which is Versed, which is a benzodiazepine, cocaine, and fentanyl, which is often compared to fentanyl, which is an opioid. So as you can see, the maximum breakpoint, and remember, breakpoint is how many times an animal will press in order to get one infusion. So the breakpoint for a benzodiazepine typically is somewhere around, let's say, 300. For Ambien, which is not a benzodiazepine but has a very similar global effect, it's maybe around 500. For cocaine, we're looking at around 1,200, and an opioid, we're looking at around 1,000. And remember, whether or not an animal will self-administer it is not the end-all be-all of whether or not it is addictive, right? If that were the case, we would expect opioids. If this was a direct reflection of how addictive it is in humans, we would expect opioids to be much higher, right? More people who use opioids will end up addicted to opioids than people who use cocaine will end up addicted to cocaine. So the BDZ addictive potential is often related relative to other drugs, and when compared to other addictive drugs, it's usually considered low to moderate addictive potential. However, when you look at polydrug users, so people who are using other drugs in addition to benzodiazepine, the risk becomes significantly higher, especially if that person is using alcohol. It is often the combination of them. They show what's called cross tolerance, meaning that if you've been exposed to benzodiazepines and have a tolerance, you'll also see tolerance to alcohol. So sometimes they will use both in combination to overcome that tolerance, and sometimes if they can't get one, they'll use the other. So polydrug users or people who started using drugs really young and have used different drugs at different points in part of their life are at a much higher risk of addiction if they take benzodiazepines for therapeutic use and then transition into recreational use. This is important because a lot of people avoid taking benzodiazepines for anxiety because they're worried about becoming addicted. If you're taking it on its own therapeutically, it is fairly safe. The probability of you becoming addicted is fairly low. You may develop a physical dependence, but that can be managed, and you can figure out with your doctor how to counteract that. Oftentimes, what the main priority is ending the anxiety, and then you can deal with the addiction if you have to, if that comes up in the future, right? We have tools to deal with that. We can figure it out. People in withdrawal, so in withdrawal from benzodiazepines or alcohol or other drugs, are also much more likely to abuse or self-administer benzodiazepine. So benzodiazepines can also be given to people who are going through opioid withdrawal just because it sort of reduces the intensity of the withdrawal symptoms. So while benzodiazepines are considered fairly relatively low risk, the current prescribing guidelines are recommend benzodiazepines mainly for short-term use. So either given acutely in response to an anxiety attack, meaning you don't take it every day, you only take it when you feel an anxiety attack starting, or for short periods of time to address specific events, right? So for example, when I was writing my dissertation, I was prescribed an anti-anxiety med because I was really worried about it and I thought the anxiety might stop me from being able to write. I was only given a 30-day prescription though, because that was about how long I was going. And then we could reassess about whether or not it was helpful. So that sort of short-term use to overcome a specific anxiety-provoking event is a very popular way to treat benzodiazepines. Right? So if somebody has anxiety, they are much more likely to self-administer the benzodiazepine. Again, this is not saying that they're addicted. This is saying that they're more likely to find it reinforcing. And this makes sense, right? Because the benzodiazepine is going to remove the negative experience of anxiety, it will be much more reinforcing for people. This sort of gives us a glimpse into the fact that benzodiazepines do not cause euphoria. They don't make people feel super great. But if you are experiencing anxiety, it can help relieve that, and that in itself is reinforcing. So people who are not polydrug users, who do not experience anxiety, often they don't show a statistically significant preference between a placebo and an anti-anxiety med, such like benzodiazepines. But when we look at humans who do have anxiety, you can see that they continue to take benzodiazepines, right? Each one of these dots is a dose that they're given, and you have a cumulative dose, right, over a week. I just had the strongest urge to ask people if there's any questions about that, and nobody can ask me questions right now, and I feel so silly. Okay, so I want to talk a little bit about the cellular circuits behind why benzodiazepines may be reinforcing or addicting. But before I do that, I want to remind you that, remember, GABA receptors are pentameric, meaning they have 5 different subunits, and the makeup of those subunits can be different, right? So, for example, the alpha-1 beta gamma-2 receptor is found in these areas of the brain, right? So you can see it in the cerebral cortex, you can see it in the olfactory bulb, and you can see it a little bit in the cerebellum. You can also see it in the amygdala, right? So here, if you activate this receptor, it would expect to see sedation, possibly an addiction or reinforcing effect, and anterograde amnesia, meaning the inability to create new memories, helping reduce seizures. That's going to be mostly because of the cortical effects, and premature cortical plasticity, which we don't really need to worry about. The anxiolytic effects, the anxiety, what most people are using benzodiazepines for, you can see there's a lot of, it's going to be dependent on the A2 beta A gamma 2 receptor, which is found in really high concentrations in the hippocampus and the amygdala and other limbic structures, as well as the olfactory bulb, which is considered a limbic structure in mice, this is a mouse brain. So you can also see antidepressant here. You can see myorelaxation, that's the muscle relaxant. So if you create drugs that target different compositions of GABA receptors, you're going to end up with different effects. And these different compositions of receptors are expressed at different areas of the brain. So it would be possible to create a drug that was able to achieve the anxiolytic effect while not having the addiction effect. Remember, benzodiazepines can bind at most GABA receptors if there's a junction between the alpha and gamma, as long as there's both an alpha and gamma subunit within the receptor, right? So you can see a lot of these different effects from benzodiazepines. You can see cognitive impairment, you can see myorelaxation, you can see sedation, addiction, anticonvulsant activity, anxiolytic. All of those things are present in behavioral effects of benzodiazepines. So you can see that it's targeting multiple different subtypes of that GABA receptor. Okay, so welcome back to our addiction circuitry, way back from Unit 1. We're looking at this VTA to nucleus accumbens projection, also known as the mesolimbic projection. GABA receptors are fairly ubiquitous, meaning that they're found on a lot of different brain regions and a lot of different neuron types. GABA receptors GABA receptors are expressed on GABA neurons. They're also expressed on dopaminergic neurons and acetylcholinergic neurons and glutamatergic neurons. They're basically expressed on most neurons to help regulate the activity. Because they're inhibitory, they're the best way to acutely regulate activity coming out through this. So without benzodiazepines, usually GABAergic neurons within the VTA will inhibit dopaminergic neurons, which would usually project to the nucleus accumbens. This nucleus accumbens neurons, in the nucleus accumbens, there are GABAergic neurons that then feed back, right? There's a feedback loop. It's a negative feedback loop because it's then going to inhibit this dopaminergic neuron. So if this is a D1 receptor and this dopaminergic neuron increases the activity in this GABAergic neuron in the nucleus accumbens, that's going to feed back and drive GABA release back onto this dopaminergic neuron to decrease its activity. Okay? When you have benzodiazepines, it's going to affect all of these different receptors, but it's going to do it to different degrees. It is going to have a much larger effect on this A1 receptor than it will on this alpha-3 receptor. So while benzodiazepines are going to increase the effect of GABA on this GABAergic neuron and this dopaminergic neuron, the effect is going to be much greater on this GABAergic neuron, meaning that this neuron is going to be very inhibited, right? Which is going to cause a reduction in the release of GABA. While these receptors are also going to be potentiated by the presence of benzodiazepines, they will have less GABA in the synapse to help that is required for benzodiazepines to have an effect. So the benzodiazepines are not going to be nearly as effective on these receptors, and GABA is not going to be present to inhibit this neuron. So we're going to see an increase in dopamine. So with benzodiazepines, we do see an increase in dopamine in the nucleus accumbens, and that's because of this disinhibition of these dopamine neurons. And this is going to be a theme that we will see with all CNS depressants. They almost all disinhibit these dopamine neurons in order to increase dopamine release in the nucleus accumbens. Okay. So overall, benzodiazepine addiction, it is reinforcing. It's not a huge effect, it's just a little bit when taken long term. There is a small amount of psychological dependence, possibly due to the negative reinforcement. It is more common with rapid onset benzodiazepines. I think there's a top hat question that I would ask you to consider why that might be the case. Physical dependence or tolerance definitely does occur. It can occur in as little as 2 weeks. So people are often afraid of these effects. They're afraid of withdrawal and becoming dependent. But while withdrawal can be dangerous, it's also very manageable. They're mostly relatively safe due to the mechanism of action. Remember, they need both GABA and benzodiazepines to have their effect. As an example, the therapeutic index for Valium is greater than 15, so we consider that safe. Anything over 10 is considered safe. When mixed with other depressants, though, like alcohol, overdose can occur, and the therapeutic index really shrinks very quickly. So benzodiazepines should not be taken in combination with any other CNS depressant. And if you are considering taking a benzodiazepines and alcohol is a big part of your daily life, you need to be honest about that with your doctor because you cannot combine them. So if you're concerned that you won't be able to drink while on the medication, you should tell your doctor that, and SSRIs might be a better option for your anxiety. Okay, so that's addiction, benzodiazepine addiction. That's basically most of what we're going to cover in this lecture. I only have a couple of slides on tolerance withdrawal, which you'll find in the next video.